Thank you for joining the VALVES session of TCTAP and AP VALVES 2020. My name is D.Y. Gang from Asan Medical Center. The first implantation of transcatheter aortic valve in 2002 totally changed the landscape of the interventional cardiology. TAVR has been a phenomenon with successful channel CTs saving millions of patients that could not survive without it. Transcatheter valve intervention is now rapidly expanding its boundaries to valve-in-valve, mitral, and tricuspid valves. Today, the pioneers of the valve intervention will share their priceless insight with challenging cases, cutting-edge researches, and ongoing clinical trials. Two masters of the valve intervention, Dr. Eberhard Grube from University Hospital Bonn and John Webb from St. Paul's Hospital will moderate this special session.
Hello, I'm John Webb, and we're going to be heading off our valve session today. Shortly, Eberhard Grube is with me. He'll be introducing the speakers, but we have a panel, Kentaro Hayashida, Samir Kapadia, Thierry Lefevre may be here, and Duk-Woo Park. And so, Eberhard, do you want to go ahead with the first introduction?
Yeah, thank you very much, and welcome to the virtual session, the highlight session number 4 concerning valves. And I would like to introduce Raj Makkar. I don't think he needs any introduction, and he'll be talking about the challenging TAVR case of the year. Raj, welcome, and thanks for being with us.
Good morning, everyone. Good morning, John. Good morning, Eberhard. It's a pleasure to be a part of this meeting. I want to thank SJ and the organizers for actually including us in this presentation. So my task today is to talk about a challenging case that I've had with TAVR this year. So these are my disclosures. So here is the patient actually that we are talking about. So this is an 81-year-old lady with referred to us for TAVR for pure native aortic regurgitation, which is because of infective endocarditis, a few months earlier. She also has severe tricuspid regurgitation, atrial fibrillation. She's status post pacemaker, has renal artery stenosis, and the list goes on of all the comorbidities there, which actually made her less than appealing candidate to the surgeons for surgery. So hence the reason why we actually considered her for transcatheter aortic valve replacement. And this is the echocardiographic studies. As you can see, there is severe aortic regurgitation. The ejection fraction is actually preserved, and you can see that there is diastolic flow reversal, and you can indeed see the color. So if you look at the CT here, you can see that the area is 435. The perimeter of the annulus was 73. You can also look at the other dimensions of the aortic root anatomy. The sinuses are actually pretty generous. The LVOT, interestingly, is actually small. So we actually presented this patient to the, for possible enrollment in the JenaValve, but she was excluded. So we were basically left with the choice of sort of dealing with this, with the commercially available valves. What I also wanted to point out here is, in fact, the severe, if you look at the LVOT, we showed you the numbers earlier. They were actually, it was small, and you can see the bulging of the septum into the LVOT as well. The next picture shows how there is absolutely no calcium. So you can see the leaflets here, and in fact, when you look at this picture on the right side, once again, you don't even see any specks of calcium. So this was indeed pure aortic regurgitation with no calcification in the valve. The height of the coronary arteries was, they were actually high enough, we thought. So 12.1 for the left main, and the right coronary artery was about 13 millimeters higher than the annulus. This is the the aorta, which was actually somewhat angulated, and this was the reason why the Jenner valve actually excluded this particular patient. The aortic vasculature seemed pretty good. So I just want to, ask, any of the panelists if they have any questions before we sort of move on and show you what we did and actually then what happened.
So the only question is, Raj, that from the available commercial valves, the three of them, which one would you select, and do you have a preference for the pure AI patients?
Yeah. So I think when in the early experience, when we started using commercially available valves, we were very prone to using the core valve, the self-expanding valve. And interestingly, what we discovered was that it was not easy to actually do self-expanding valves, the core valve. We had some great results, but also it wasn't easy with very frequent pop-outs. Okay, and so we have now used in quite a few cases the balloon expandable valve, and I think that when the annulus is very large, obviously I think you've got to use a self-expanding valve or a combination of. You start off with the strategy that you're going to create a landing zone with a self-expanding valve and be ready to sort of use a balloon expandable valve within the self-expanding valve. In this case, for right or the wrong reason, I think we did think back and, we thought we could use either one of the valves. In fact, I think the annulus is not that large. The sinuses are generous. So we could have used a self-expanding valve. But because of our increasing comfort with the balloon expandable valve, that's what we actually decided to use. I've never used a Lotus valve in pure aortic regurgitation.
That's what I was going to ask you, that how about the mechanically expandable valve? So
Yeah.
Lotus would be a good, because the size is good.
Yeah.
Yeah.
Okay, so here is the case. Essentially, we went ahead and we used, so we've been playing with the sizing of these valves, and I think you have to generously oversize, but not too generous. I think we find that between 20 and 30% is the sweet spot, if you want to call it so. So we used a 26 millimeter valve here. We left a CC within the, we left the CC within the balloon. I mean, it looks reasonable there. I think it seems like that it is actually well deployed, and we didn't, we looked okay. But after a little bit of discussion, the slide sort of gives it away. We decided to post-dilate this because we thought that maybe there was a little bit of perivalvular leak, and maybe that was the wrong thing to do. So you can see that as soon as we post-dilate, the first time around we were sort of lucky. We were more precise in that despite the bulging LVOT, we had landed it in the proper position, but with a little bit of post-dilatation, the valve embolized. So here we were essentially left with a valve that has embolized. Now, this has become a rare thing, in the early days, it wasn't uncommon. In fact, right, we used to have valve embolization about 1.5 to 2% of the times, and we had learned how to deal with these things. But so here is the here is the case. So any thoughts, John or anyone on the what should be done at this point?
My question is that why did it embolize? And I think the reason why it embolized is because, as you mentioned, it is oversized and the LVOT is small. So when you inflated a balloon, it squished it out.
Yes.
That is why I think it came out, because otherwise with post-dilation and proper pacing, it should not embolize. So this is a oversizing, and narrow LVOT with a mitral valve repair. I think all of them contributed to the.
So just one comment about the selection of the valve. I think it's very difficult when you have septal bulge because the risk of embolization, as you have shown. One problem is that the mean diameter in this particular case is 23.8. So selecting a 23 will be, of course, too small, but 26 a little bit too large. So the risk of the increasing risk of distal embolization with 26, I think, is high. So I think in this particular case, I will select an Evolute R29, for example, or Accurate Neo large, because the risk of embolization is, I think, lower. But of course, septal bulge does not imply that you should use self-expanding valve. But in this particular case, I think oversizing was the main mechanism of embolization. So the next step now, of course, the valve embolized. So the next step is to select a different valve, because if you use a 23 S3, the risk embolization will be also very high because it's too small. And another 26, sorry, you will have the same risk of a second embolization.
I'd agree with that. So Saibal, what did you do?
So I would have used, as you know, I haven't done as many as Raja's, but the few AIs I've done them with Evolutes. And Raja, what I found is in this one I would have used a 29 because it's 73.4. And what would do is that when I do AIs, I pace till the end, even beyond 80%. I keep pacing till the upper crowns, the upper end of the Evolute valve expands. And only then I stop pacing. Actually, no, I don't even stop pacing. I actually reduce the pacing. I go slowly down. So we're like 160, 130, 140. So I think I would definitely use a self-expanding valve. The only thing about it is that the angle is 66, so it's a bit horizontal. And that's it. Now, regarding what happened, I agree with Samir. The issue was obviously you oversized it, and the LVOT being small, and melon seated it up. And so now the question is, are you obstructing the carotids over here?
Yeah, so I think that's the important question, right?
If you're obstructing the carotids, then you have to push the valve down and then put another valve inside it, or a stent, or you have to try to pull it out.
Okay. Yeah, so I think the important thing here is not to sort of obstruct the flow of the great vessels. So the upper cell is, of course, there's no cuff there. So if it was right there, if we could stabilize right there, that would be okay, because you've got flow into the brachiocephalic and you've got flow into the carotid. There is a little bit of pre-existing disease at the ostium, but it was not possible. So to really anchor it there, we tried anchoring it there, and every time you would actually sort of inflate the balloon, it would actually sort of move. We tried to bring it back because in the past, in the early days of TAVR, we would always ride this thing on the reliant balloon and sort of gently bring it back into the descending aorta beyond the subclavian and sort of anchor it there. Most of the times, we would actually anchor it down in the abdominal aorta, preferably actually below the renals. So that's what we used to do, but it wasn't. You can see the angle there, and you can see the calcium in the aortic arch. So I think that's the other important thing.
So you tried to drag it down.
Yeah. So basically, we could not bring it back. So the question is, you have to anchor it somewhere here in the ascending aorta. Okay. So otherwise, the risk we thought of creating aortic dissection was too high. So in any case, we went ahead and we used the next sapien valve. We got a nice result. We decided not to post dilate, and we took care of this with the and we just were a little bit lower. Okay. In fact, we gave a little bit more volume. In fact, all right, and we were able to do that. So then what we did was. To anchor this safely became the most important objective. So we took a Evolute. We've used in the past. We've used the PAMAs, and sort of anchored these things but we thought that the risk was too high of using a PAMAS given the calcium, and we thought a safer thing to do would be to sort of use an evolute valve. But what we did was we needed a large self-expanding stent, and there is none. So what we did was we cut out the leaflets of the evolute valve, okay, and then used that to anchor this. So this is now anchored in the ascending aorta, and there is, if you remember, there was actually the brachiocephalic, which was coming out here. All right, so this is all proximal to the brachiocephalic, and it is nicely anchored. And this was the echo. Basically, the valve worked well. The patient was extubated, and the patient was discharged home the next day. So I think I'm going to go ahead and end there, and then we can sort of ask or discuss any other.
I think super well done. There is a, sometimes just as a technical thing, if you cover the great vessels, these days you can use a laser and just dig a hole and put a stent in the valve. So if it, again, the embolization is rare these days, but let's say you ended up covering it, you can just put a laser, it goes through the valve, sinuses, and then you can put a stent and make it bigger. So this is an option that sometimes can be useful, but otherwise this was even much slicker and nicer.
Yeah, it was expensive. It was expensive, right? Yeah. I mean, I think what we need large self-expanding. So, I think retrospectively, because see, we got very comfortable. In the last couple of years, we did almost 20 cases with the SAPIEN 3 valve, and we had beautiful results. So it was a shift for us, but nonetheless, this case sort of highlighted the importance of being open-minded and considering other valve designs in aortic regurgitation. And I think if we had access to the accurate, I think that would have been a great valve too, to actually use it in this particular case. But it's not approved in the United States. As you know, we're just using it in clinical trials.
Raj, that was an excellent case, and 3 cases in one. But I think we better move along. Eberhard, do you want to introduce the next speaker?
Yeah, I just wanted to have one question. Why do you? I mean, if you use the second, SAPIEN, you think that oversizing and the deployment a little bit deeper prevented it from moving up this time?
Yes, in fact, we discussed quite a bit, and it was so we actually thought that we needed to be a little bit lower, and of course not post dilate. That was our theory, and it seemed to be, it seemed to have worked.
Yeah. Okay. Well, thank you very much, Raj. Excellent case, beautiful learning, and thanks for the comments. We continue.
Okay, Laja, I got a very simple question about that. And so, would you tell us, that this is very uncalcified, pure AR, and so if you use the SAPIEN 3, how much, total area all sizing for this kind of AR patients by CT measurement, something like that?
Yeah, so this is what we do. We try to oversize 20 to 30%, and we're also looking at the inflation device to see where so the person who's actually inflating is a very important cooperator. So I think once it starts reaching 6 atmospheres, 6 atmospheres, I think you can start to leave some volume. So I think it is about 20 to 30% oversizing, and at the same time looking at the inflation device, which becomes an issue when you're using a large valve because the 29 doesn't have a pressure gauge. So I think.
All right. In many cases, more than I am. Actually, the reason will be less calcium by CT measurement. Recently, we tried 15 to 20% area oversize, even in the aortic stenosis with a relatively less calcification we did a little bit larger percent area, oversizing 20%. Sometimes we want to make it 25%. Another point is, if calcification is very low, less than 400 something by CT, we use a little bit bigger, device selection, and that on the field is less than. For example, for particular these cases, we're gonna use when you deploy the S3 device, it's still there are enough distance between the analog side and device side. So exactly, we're gonna choose the 29, and then we're gonna less than 2cc, 1cc, and then we're gonna accommodate a final result. And so meaning is even in the calcified aortic stenosis, less calcium. Actually, we selected more than 15 and 20% oversizing area, right? So that is the reason why the person.
Again, nobody needs, an introduction here. Saibal, for your case on the MitraClip case of the year. Saibal, great to have you. If you could share the screen with us.
So I'm going to talk about a challenging. It's not going to be as exciting as Raj's case. It's going to be a little bit more simple. And I want to thank Dr. S.J. Park and Marty and all the big shots over there to allow me to present. I'm actually quite intimidated by the whole thing.
Of course.
So I'm going to talk about an 85-year-old gentleman who happens to be a father of a cardiologist. That itself makes it a challenging case because they start advising you what to do. So he's a known patient of MR for several years. He had fatigue for the last few months. He had atrial fibrillation for the last few months. And so when he came to see me, he was debating whether he should have an AFib ablation or not. And being a father of an electrophysiologist, that's all that kept in his mind. And I said, no, I think you should start looking at the structural part of your heart first. So this is just his echo. I don't want to show the details, but I want to show you this three-dimensional end-face view of the mitral valve. This is the anterior leaflet. As you can see, that's the posterior leaflet. And there's a medial commissure. You can see a prolapse of the P3 commissural spleen. And then you see an eccentric jet running from the medial aspect right laterally. And it comes right from the end of the right over there, going right across from the medial to lateral, almost close to the appendage. In fact, Bob Siegel used to say that if you see a jet going to the atrial appendage, then that's a P3 flail. So then I'll go to the next slide, and this shows you slightly better. You can see over here, this is the bicommissural view. This is P1, this is P2, and this is P3. And you can see the jet is arising from the medial part and extending, going laterally towards the appendage. And there's a tiny jet laterally. So the question we had for this gentleman that, first of all, I think most people, I haven't shown you all the other 5 findings, but the pulmonary veins was actually reversed in the left upper. In the right upper, it was blunted, suggesting that it's significant MR. And so the question is, what do we do with such a gentleman who's 85 years old? So we consider cardioversion and start Eliquist, since he's an EP physician, AFib ablation, since his son is an EP doctor, surgical mitral valve repair, surgical mitral valve replacement, enroll the patient in the randomized trial Apollo trial for replacement, MitraClip or Pascal. And do you have any suggestions from here? The audience?
MicroClip is the better option because, going in the commissure is easier. Pascal, I have not personally tried, but I think a little bit bigger device and potentially also doable. These are the 2 real options that you have. And typically, the commissural MR is beautifully treated with the clip, or Pascal clip is probably, I have more experience with the clip to say that it is one of the most satisfying thing to treat a commissural MR because it doesn't cause any MS and it gets rid of the MR. beautifully. Of course, you have to be careful, and you are super experienced, so you can put it there. But go with a close clip, put a smaller clip, not the larger clip, and put it in the corner. Of course, you have to stick a little higher because of the medial commissure. It's a good case to do with the clip, in my opinion.
So you said, what was your other option? You said, I didn't hear it. You said
Pascal.
clip and one. Oh, Pascal.
Is a little tricky in my mind, but the advantage would be that you will not be caught in the commissure because you can come in and out easier. As I said, I have not tried it enough to say whether it would work with the Pascal in the commissure or not. So
there is a smaller Pascal available now, so I think it would work fine as well.
You can use the smaller P5, right?
P5, yeah.
Yeah.
Is that what you would use, John? You would prefer that?
Either.
Either, okay. So we, for the reasons actually that Samir said, we decided to use the MitraClip. And I just want to just talk about the MitraClip Generation 4. Now we have the Gen 4 MitraClip, which basically has 4 sizes. You can see over here that you have the NT, which is the standard size, and NTW, which is 6 millimeters. And this is the standard MitraClip, which we started with all the years. And then you have the XT, and then you have the XT wide. And then, of course, you have the independent grippers, which allows you to capture or actually reposition leaflets easier. And with 4 sizes, you can choose the right clip for each mitral valve pathology. Just a disclaimer, it's FDA approved. It's not yet CMARC approved, and it's not yet approved in Asia, the Gen 4. So having said that, the strategy would be within the 4 options. The option which I thought was the safest was to use an NT because it's in the commissures, as Samir pointed out. The leaflet span is smaller, so I used a smaller clip. And because you can get entangled in the cords in the commissures, I used a narrow clip and said I would rather use 1 to 2 NTs rather than using an NTW, which might get caught in the cords. For these reasons, I chose to use a NT and said I may need more than 1. So as Samir again pointed out, it's very important to make sure that the puncture site is higher than normal. So we actually did about 4, we only got 4.2 centimeters. And then the important thing is to orient the clip. And you can see over here that we are orienting the clip, and it cannot be 6 and 12. It has to be 10 and 4 because you're on the commissures. And so we have to orient the clip above. Then it's very important to orient the clip below. And it's important not to rotate too many times underneath the valve because you can actually entangle the cords. And then finally, when you grasp it, you should still, once again, make sure the orientation. This is clear in MitraClip. You orient above, orient below, and then after grasping. So you can see we're quite medial. And then after that, we actually grasp the leaflets with not much of a difficulty. And then when you see here that you grasp the leaflet, the question is, should you accept this grasp? And the answer is yes. And the reason for doing so is, number one, you can see you're actually very medial. If you see also here that the flail has gone away, you can't see the prolapse anymore. And third, if you see the jet, it was a horizontal jet, and the horizontal jet has gone away, and now you're left with a vertical jet. So whenever you see a eccentric jet that's actually gone away, you know you've reduced the MR, and this is just a residual jet which you can leave behind or you can treat it. And then you can see there's a lateral smaller jet, which is probably not important. I'm sorry I didn't show the simultaneous LA pressures. The other thing that I often do in these patients, I constantly measure left atrial pressure during the entire procedure. And one of my criteria for deploying a clip is to see a reduction in the V wave during deployment. So all of these criteria were fulfilled, that the flail has gone away, the jet is converted from horizontal to vertical, and the V wave came down, so this clip was deployed. So once we deployed that, we actually saw that we had a very large orifice. We had a small residual prolapse on just the lateral to the clip, and therefore it became much more easier now to put a second clip over here. We went very close to the first clip in the same direction, not 6 and 12, but 10 and 4, and then closed the clip and then advanced it. And then once we deployed it, you can see there's just a small intra-clip jet and a tiny lateral jet. And it's important to look at this lateral jet because you don't want to distort the valve. And you can see the swirling of spontaneous contrast that's increased in the left atrium, which is a suggestion that you've actually reduced the MR. That's why you get the spontaneous contrast, which you notice there, which is often a good sign. And the mean gradient was actually only 2 millimeters after we did this procedure. So when you see this, now you can see how there's just 2 jets over there, a tiny little jet over here, and a very wide orifice that's left behind. And you can see those 2 little clips are hidden in the corner. The prolapse has gone away, and it almost doesn't, it seems like a normal valve. So as Samir again pointed out, commissural jets are a little bit difficult to do, but you get one of the best results when you treat commissural jet. And so this was the end result of this patient. His subsequent care, he was discharged home the next day. He had trace MR discharge. He was cardioverted in 3 weeks. And if there's a recurrence of AFib, we will consider a left atrial appendage closure. So my conclusion is that the new generation MitraClip will help improve the efficacy, efficiency, and safety of the procedure. And the choice of the clip will depend on the pathology of the microvalve. Thank you very much.
Great case, Saibal. Very well done. It's easier said than done in the sense that although we like to do this, sometimes you get tangled. You cannot go all the way in the medial commissure. Have you had a situation where you cannot go all the way medially and you put it just outside, and if there's a leak more medially, then you can put a plug? Have you used that?
I've actually done that. I've actually, so what Samir said is one of the downsides of doing a P3 flail is that it's sometimes very difficult to go very medial because you don't have a guide. The guide tip has to come out. And so you're left with small medial jets medial to the clip. And that becomes a difficulty, and that you can't put another clip, but you can put a plug. And the plug that you use is, you should not be using a regular ASD device because you'll get hemolysis. So the only 2 things that you can use is ADO2, Amplatzer duct occluder, or an AVP2, because these are micronitrile meshes where you get less hemolysis. So I've actually reported 8 cases of that, and I've shown that you can actually do that. You can use an ADO2 or an Amplatzer duct occluder.
And I also saw some case reports of people using now the cardioform device. Of course, it's you.
Well, I did that. That was a different case. I was the one who reported that case, but that was a case, it was a very large hole. And I put in a VSD device and there was hemolysis the next day. It was terrible. So I had to retract that whole device, bring it out, and then stick in a cardioform device. But that's for a much larger gap. This was a very small, this one.
So Saibal?
Yes.
So congratulations on your great case. So I have a question. So actually the generation 4 is coming to Japan in September. And you chose NT for this case, not NTW. So which kind of lesion do you think NTW is better? Especially
so actually, if you look at the last expand data, NTW tends to be the workhorse clip. You read that, Raj? It's NTW is becoming one of the most common clips used in general. For most functional MR patients, NTW is the standard. So, and then the next size that is used most commonly is XTW. So the reason why I showed this case is there's still a role of using small clips, narrow clips. And I think there are 2 considerations when you use it. Number 1 is what I showed in commissures where you can get caught in the cords. Number 2 is that when you put one clip in, a larger clip, and then you have a residual jet, the second clip can often be just anti-narrow. So that's the reason why. And by the way, I've done cases in Japan. You don't need long clip arms in Japan. Most of the cases I've seen in Japan, since the anteroposterior diameter is quite small, especially both in India and Japan, simple NT and NTW will be more than sufficient.
Okay. Saibal, I think the choice between XT and NT, when it first came, we were all very enthusiastic with the XT, but we all had, some tears because I think it does, especially in functional MR where the leaflets are very thin.
Yes.
So for us now, for functional MR, it is NTWs,
Right.
that has become the primary. For large flails and big prolapses, of course, you tend to go towards XTs, and whether it's XTW or XT, depending upon where the pathology is located in the middle or whether it's in the commissures.
Yeah. So I
So
actually
Saibal,
agree with this.
Do you think that a small Pascal could take care of that middle of that medial jet?
Yeah, in fact, Saibal, you have done, when you were here, we actually did
the first case, that's
commissure with the use of the Pascal, and now with the P5, it would even be much easier. So I think that you can address commissural pathologies with the.
But Raj, I've also done experimental things with Pascal. And by the way, what Raj said is correct. The first Pascal done in North America was a P3 and a P2. But it does, you can entangle, if you use wider paddles, you can actually push the cord. And see, when you have a lot of cords, the clip or the Pascal system has to go in between the cords, right? But if it's wide, it can push the cords aside. So that's something that can happen still. So I still think that when you go on the sides, I think would use narrower clips, whether it's narrow clip or P5, it's okay, but not the wide ones.
Yeah. Okay, I think we are a little bit time over. SJ, any comments from your side? No.
Oh, it's okay. So it's great.
Okay, thanks very much, Raj and Saibal. Very, very nice cases, very instructive. And thanks for getting up early to teach us. And I think now we can move on to the next session. Thanks for joining. We can move on to the next session. And Dr. Leon, Dr. Dangas. Dr. Leon will be talking about the TAVR long-term durability. Is it concerned for late catch-up in partner 3? Marty, great to have you again. And thanks for joining us.
Well, after hearing these and seeing these two marvelous cases, I feel a little odd now giving a lecture because it's always more exciting to think about cases. And in the early days when we worried about things like valve embolization, and we had a lot of paravalvular leak and vascular complications, we agonized over those complications. Clearly now those things have gotten very much better, except Raj showed an interesting valve embolization earlier. And we focus on other things. We focus on considerations like permanent pacemakers and conduction abnormalities. And we also focus on durability. So durability now, I think, is going to be the big issue that we have to deal with in the future as we talk about TAVR. So that's what I'm going to address. And I've been asked to respond to this question. TAVR long-term durability, is it a concern for late catch-up in partner 3? These are my disclosures. And the simple answer to the question, is it a concern, is yes. Of course it's a concern. It's a concern for all TAVR systems right now where we do not have the rigorous long-term data. So durability will continue to be a concern until we have more data. But let me try to present some of the issues and show at least some of the data we have with specific reference to the SAPIEN valves, because the question was partner 3. So the first issue for me is really this issue of clinical catch-up. Are there changes in some of the hard, important endpoints over time that would suggest that the benefit of TAVR is diminished over a long-term follow-up? And the second is a more detailed analysis of the valve itself, focusing on this issue of structural valve deterioration, which is really what most people associate with valve or bioprosthetic valve durability. So let's start with the clinical catch-up, and I'll try to quickly present some of the data. In the earlier TAVR versus surgery randomized trials that have at least 5 years follow-up, which is really midterm follow-up, in patients that are either high or intermediate risk, including either the balloon expandable or self-expanding valves, there is no indication of late clinical catch-up that would favor surgery.
The most recent of these studies was presented by Vino Thirani. It was published in New England Journal of Medicine, and Raj Makkar was the first author, which is the 5-year follow-up from partner 2A. Now, this is the Sapien XT valve, which is no longer used. It was the largest randomized trial, over 2,000 patients. And you can see death or disabling stroke, the primary endpoint out to 5 years, really showing no important differences. This is the ITT population. Now, 75% of these patients were treated transfemorally. And if you look at the transfemoral cohort, again, there's no evidence of catch-up of the hard clinical endpoints over time, death and stroke. Now, the most recent online TVT, which was just a month ago, we did a propensity matched analysis of not Sapien XT, but Sapien 3 versus surgery in intermediate risk patients, now with 5-year follow-up. And it again showed no late catch-up. This was presented by Sushil Kodali only a month ago with the valve that most people are using, the Sapien 3. This is quite similar to the Sapien Ultra. And this is a matched cohort, over 1,500 patients, looking at mortality out to 5 years. And you can see there's really no difference in this propensity matched analysis. And if we look at the endpoint that many people focus on, death or disabling stroke, again, no difference with a slight numeric advantage, still favoring TAVR at 5 years. So no clinical catch-up. Now, what provoked some interest was the recent ACC report. And this is only the 2-year follow-up of partner 3. So this is Sapien 3. It's a randomized trial. It's in low-risk patients. And we did see some narrowing of the death stroke endpoints, still favoring TAVR, but narrowing of the difference. We also saw some increased valve thrombosis between 1 and 2 years in the TAVR group. And this was presented by Mike Mack on the online ACC meeting. And now you see the death or disabling stroke event rates at 12 months. And you see that there were a trickle of additional events, more events in the TAVR arm between 1 and 2 years. So the delta was reduced from 2.1 to 0.8%, still favoring TAVR. Now, when you have such low event rates and you see some of these random events occurring, it's a little bit hard to know if this is clinically important. But this is something, of course, that we would be watching over time. We also looked at valve thrombosis using the older VARC2 definition, and there were 13 episodes in TAVR at 2 years versus 3 in surgery, which was significant. The majority of those had mean gradients that were greater than 20 and had an increase of the mean gradient of at least 10. But interestingly, none of these patients had clinical events. So it's a little bit hard to associate this with the findings of a slight increased number of death or strokes. So let me turn my attention now to structural valve deterioration. We've been trying to focus on the clinical catch-up data. I'll first mention that the earlier definitions of valve durability have always focused on very soft clinical endpoints. And these were reoperation or presumed valve-related death, which I think most people would agree clearly underestimated the true frequency of structural valve deterioration. And recently, we've now seen standardized definitions that have been developed, and this really focuses on prosthesis-centered and patient-centered outcomes using serial echocardiography and careful longitudinal follow-up. And we now report valve durability accounting for competing risks. The first such standard definitions came out of Europe. Danny DeVere did a slight modification, and most recently, we've just submitted the VARC3 manuscript, which has an even further refinement on these standardized definitions. So these have now been published since 2017, and they're very comprehensive, and I think it allows us to have a level playing field when we look at bioprosthetic valve function. And we have these somewhat esoteric definitions of what structural valve deterioration is. If you apply these standardized definitions for structural valve deterioration and bioprosthetic valve failure, which also includes clinical events like reoperation or reintervention or valve-related death, and you look at all this Sapien 3 analyses versus surgery, which we're going to look at, you'll see no important differences between surgery and Sapien 3 in structural valve deterioration. the most important report that referred to this was at London Valves last year, and this is Philippe Pibereau and Becky Hahn presenting a very careful analysis of the P2A study. This is intermediate risk. And you see three groups. You see the randomized group, which is P2A surgery versus Sapien XT. And interestingly, there was a difference. And the difference favored surgery. And then layered on in orange, you can see the S3I, the intermediate risk Sapien 3 results at 4 years, which are almost superimposable with surgery. This points out two things to me, that there can be, and I think there will be, differences among the valves. And you have to analyze each valve independently before you make conclusions about structural valve deterioration. Another way to look at this, rather than Kaplan-Meier curves, is to look at the rate per 100 exposure years, which is a more traditional surgical endpoint that people look at. And again, you can see that Sapien XT, much more so than surgery, and Sapien 3 had more in the way of structural valve deterioration. This also translated when we look at bioprosthetic valve failure and you add clinical events to basically the same finding. Sapien 3 was similar to surgery. Sapien XT appeared to be worse in this intermediate risk group. Now, we've also looked at the matched cohort that I mentioned earlier that Sushil Kodali presented. So these are carefully matched patients, about 1,500 patients, looking at 5-year echoes. And you can see here that there really were no differences in the mean gradients. Looking at this matched cohort in the intermediate risk patients out to 5 years. And if you look at the same kind of analyses of both structural valve deterioration and bioprosthetic valve failure, we saw no differences in the Sapien 3 versus surgery matched cohort. And finally, if we look at the Partner 3 trial, now we only have 2-year data. With the same kind of rigorous analysis, we do not see important differences between Sapien 3 and surgery in this randomized trial of 1,000 patients out to 2 years. So I've tried to present at least the data that we currently have on durability as it relates to Sapien 3. There's no evidence of important clinical catch-up that would favor surgery through 5 years of follow-up with Sapien 3 TAVR. Using standard definitions and serial echoes, there's also no evidence of increased structural valve deterioration or bioprosthetic valve failure associated with Sapien 3 TAVR compared to surgery. And that's the 5-year follow-up in the intermediate risk group and now 2-year follow-up in the low risk group. But the caveat is that truly when you're talking about durability, you're talking about late follow-up, more than 10 years, these data are not available, either for self-expanding or for balloon expandable valves. And even the midterm, which is more than 1 year follow-up in low-risk patients, is very limited. So we're going to need to wait longer. Everybody has to stay tuned because it's going to take at least another 5 years for us to have sufficient data to make meaningful inferences regarding the true Sapien 3 durability as it compares to surgery. Thank you.
So you have some concerns that not all valves will have the same kind of durability. There's lots of new valves coming along. How do you think we need to address this? I mean, should newer valves just be used in patients without longevity, and we wait 5-10 years and then they can be opened up to low risk patients? Yeah, are we ever going to have this data? How are we going to ensure that it actually gets out? Can you just
this is going to be it's a horrible dilemma, John. I would argue the same thing with surgery. I mean, we have our surgical colleagues who are using newer valves that have 1, 2, 3 year experience. And the sutureless valves, as an example, there's really no durability data, just the assumption that based upon valve material and previous surgical experiences that you can extrapolate similar durability outcomes. So it's going to be a real issue, I think, to take 1 year data and to simply assume that the valve is going to function as well at 5 years. And that was a hard-earned lesson from Sapien XT, which clearly was an inferior valve from the standpoint of durability compared to Sapien 3.
So Marty, thank you very much. What do you think was the main reason that XT and S3 were different in terms of durability? What were the factors that influenced it most?
It's a good question. I mean, both valves were processed with similar decalcification methods. The geometry of the two valves are different. The leaflet length is different. I think the expansion profile of the frames were different, and the stress forces were different. And even though we tend as clinicians to pay not much attention to all of these subtle things, it's clear to me that some of these differences will become important as it relates to long-term valve function. And maybe John has insights about what your thoughts are about SAPIEN XT, John.
So, Martia, I have a short question about valve thrombosis. You have shown that there is some difference, not a lot, but some differences between TAVI and surgery. Did you have the opportunity to look at the predictors of valve thrombosis in this study, especially the role of underfilling the valve? Because I'm sure that overfilling is okay, but underfilling may play a role in the risk of valve thrombosis. So any idea about that? What do you think?
It's a good question. There were only a few episodes. The event rate is very low. In a 2,000 patient study, there were only 13 events. So it's a little over 1%. So with such a low event rate, it's a little bit difficult to develop predictors. We did look at valve size to see if there was any suggestion, and we did look at final valve expansion. And at least in this small series, we could not see anything that was obvious that predicted valve leaflet thrombosis. I mean, this is not CT. This is leaflet thrombosis that was based upon echo findings or some other change that caused the investigator to want to put the patient on systemic anticoagulation.
You know, Eberhard, I wonder if we should move on. We're running out of time. That was a fabulous talk, Marty. But we want to give a little bit of time to George Dangas, who's going to tell us about antithrombotic therapy in TAVR. So, George, you want to go ahead?
To go over the antithrombotics questions, and indeed, this year, 2020, we're going to have the chance to see that we have actually some results to share and discuss, and not just this slide we've been showing for a long time, but this perfect introductory slide, and includes all the risks that are peri-procedural and post-procedural and transition into chronic. And clearly the calcific nature of the disease of the aortic valve is closely associated with atherosclerotic burden, future cardiovascular events, and there is some increase over time. Obviously, there is a bump around the procedure, particularly in the very early stages where the equipment of the procedure, etc., were not as refined. And also our techniques and I would say that all the technologies, including perhaps distal protection that we have now, have some to do with the initial bump. Atrial fibrillation, particularly new onset atrial fibrillation, had been blamed quite a bit into those phenomena. Now we recognize that atrial fibrillation, new onset after TAVR, is much less frequent than after surgery, considerably less frequent than surgery, and maybe has been a little bit de-emphasized. And clearly, we also understand that the frailty of the patients is a lot related with bleeding, and the age is also related with bleeding, and we have to kind of counterbalance that behind any kind of theories we may develop on how to protect the valve by anticoagulating. The early reports brought up the fact that the technology is able to show us microclots, and the bioprosthetic valve thrombosis, either surgery or TAVR, is multifactorial. The surface factors, hemodynamic factors, and hemostatic factors, and interrelate obviously with the sizes and types of valves we put or we place in order to make this phenomenon, which may be mostly subclinical and rarely clinical. Just this one slide to highlight that the surgical bioprosthesis and durability has been highlighted for quite some time. And in the pictures, you can see that the degeneration and the thrombus may look very different in a pathologic specimen, but that may be very different to distinguish when you look at it from the non-invasive imaging techniques, including including the CT. So, and also to underline that although this session has been focused in TAVR, the durability affects a lot the surgical valve prosthesis as well. It's just that traditionally they haven't really been studied as much, exactly also due to the fact that the four-dimensional CTA has emerged rather recently. Therefore, we really had no reliable way to look at valves, let's say 10 years ago, or clearly not at all before then. Another phenomenon we also understood with the help of many of the speakers of this session and the leaders of the partner trial, and particularly Raj presented this at TCT just 6 months ago or so, and indicates that the subclinical thrombosis, not only does it exist, but it also fluctuates. And that's a very important phenomenon, because this study was randomized surgery versus TAVR, but there was no difference in any kind of therapy. So we have a fluctuation documented, and the rates of the thrombosis by the 1 year kind of caught up between the two techniques, although by 1 month maybe there was fewer with surgery. Similar results were shown also with the self-expanding valves, and I just selected to show just a little different slide from this presentation that otherwise was qualitatively again validating the fluctuation of subclinical leaflet thrombosis, but also indicated that again there is whatsoever not much difference in the gradients that echocardiography measures. So again and again, I would say, has been reiterated that there isn't a simple way to qualify these patients. And as much as we all kind of have a red flag to kind of think about the jumping gradient, this doesn't occur as much, and for most time the gradient is unreliable. Initially, Raj again presented that beautiful images unequivocally indicating that if you give some kind of anticoagulant, of varying types and varying doses were reported. This was essentially a large series of case reports and registries. Then you do have some resolution of this phenomenon. So let's go down to the two types of data that we start accumulating this year. First, dividing the patient to the first group that, except for the valve, there is no underlying reason for oral anticoagulation in such patients. Could we employ some form of anticoagulation in order to beat up this phenomenon that is called leaflet thrombosis of some sort, that perhaps may be attenuated over time, perhaps not? It does fluctuate. It is associated maybe with long-term durability, unproven theory, and it doesn't seem to have an immediate relation with the strokes as we initially thought. Anyhow, we first of all, in these patients, we have primarily an antiplatelet strategy. Several results indicated that the clopidogrel itself may not be as essential. There was an addition of yet another one in last year, that the clopidogrel loading in a secondary analysis of the Bravo 3 multicenter trial, they really didn't have much to do or to offer as far as any endpoint, and has had a disadvantage of vascular complications. And no matter how we looked at the different events, this was evident, and therefore, that is yet another, I would say, a small piece of data in the puzzle that leads us towards maybe creating a definitive trial to abolish the clopidogrel utilization. And the largest trial thus far is just 200 patients. Very difficult to enroll in such patients a few years ago. I want to remind you, because it is the largest. It comes from Canada, and not only was the NACE lower with the aspirin, but also there was both the bleeding was less, as well as, interestingly, there was no penalty at all for stroke or TIAs with the aspirin alone strategy. So we do have some encouraging results, and actually unexpected results. The more you study these randomized trials, the randomized studies, you see that actually there are a lot of puzzles that you wouldn't expect when going in. And talking about another puzzle, we also conducted the randomized Galileo trial in 1,600 patients, and including a sub-study of 250 patients of 90-day, 3-month CT angiography in order to evaluate the leaflet thrombosis itself. And we went in with a very ambitious and controversial theory that if we use a medium dose rivaroxaban, 10 milligrams daily, we may have a good effect in the valve leaflet thrombosis, and perhaps that's not too bad as far as bleeding. Interestingly, the study was criticized a lot about whether the rivaroxaban 10 milligrams can have any effect on the leaflet thrombosis, whereas most people believe that only full dose anticoagulation would have such an effect. Interestingly, the study found that there was an increased overall event rate as well as an increased mortality. Disappointingly, and even more puzzlingly, the mortality was the main driver of these results, and it was mostly evident. The difference in mortality was mostly evident in the group that had, for whatever reason, dropped out of the randomized on the random assignment, and several months after this occurred happened as well. So the DSMB and all of us could not have a reliable explanation of why that could be. And it did happen in patients that in the vast majority did not report any other event beforehand. The bleeding, as expected, tended to be on the red for the rivaroxaban group, even with a smaller dose than the average AFib dose. However, I don't think these results were unexpected. We were hoping to have just a trend, higher bleeding according to the VAR criteria. This was shown. Unfortunately, the puzzling results were the immediate previous one in the NACE and the mortality. More interestingly, the criticism regarding using a low dose to prevent the valve thrombosis or the leaflet thrombosis was also found to be completely unfounded. Interestingly, even the low dose of rivaroxaban has a profound effect in reducing leaflet thickening, reduced leaflet motion, or we had a table of as much as maybe 10 or 12 such definitions, and all of them were significantly reduced by the low dose rivaroxaban. So somehow there was a lot of effect at the leaflet level, but at the patient level, there were disappointing results. The ongoing Atlantis trial is a two-strata trial. One of them will address and provide further data on comparing dual antiplatelet or single antiplatelet therapy against a full dose apixaban, 5 milligrams twice daily in stratum 2, as you see, in patients with no indication for oral anticoagulation, as it also continues with stratum 1 in patients with having need oral anticoagulation in vitamin K versus apixaban. Which leads us to the second part and briefer part of the presentation on the patients who do have an underlying oral anticoagulation and what kind of studies do we have ahead of the results of the Atlantis trial cohort 1, as I just explained. Interestingly, there is some cohort data, first of all, coming from Germany and comparing the apixaban versus vitamin K, and in this preliminary, I would say, initial pilot study presented a couple of years ago, that was encouraging for the use of apixaban versus vitamin K. More importantly, this year, we had the results of the second cohort, the oral anticoagulation cohort of a randomized trial from the Netherlands. The so-called popular TAVR was published earlier this year as far as cohort B, oral anticoagulated patients, whereas cohort A continues and it will be presented within the next year, I would think. So in this study, the investigators found that there was predominantly great amount of events in the beginning in the combination therapy of oral anticoagulation plus clopidogrel versus oral anticoagulant monotherapy. And again, anyone can see that the bulk of the events did occur up front as well as within the first month for the most part. And you can see the bleeding endpoint on the left and the ischemic endpoint on the right. Let us all understand that the most TAVR procedures in this study were performed on uninterrupted oral anticoagulation, which is a practice that they pioneered in this clinical trial, but probably a procedural fact that I don't think many follow worldwide, and we can come back and discuss that impact in our discussion part. We also have the another news in 2020, the completion of the enrollment of 1,427 patients in the envisaged TAVI-AF trial on patients with AFib and TAVR, randomized into warfarin or edoxaban. Obviously, edoxaban can be dialed down to 30 milligrams if needed for a reduced renal function. We hope to continue the follow-up to end the follow-up in the end of this year. And this is just a snapshot indicating that there is a lot of possibilities out there. Mono antiplatelet, dual antiplatelet, combinations with anticoagulants, types of anticoagulants, a lot of activity out there, and not a lot of randomized evidence, hardly any one could say. So in conclusion, we have reviewed that the leaflet thrombosis post-TAVR can be high. It's similar to SAVR by a year in multiple studies, and its clinical indications are not very well understood. Initially, we're very alarmed about stroke or TIA. That doesn't seem to pan out as a major risk right now. There is a question of the contribution to a limited or shorter valve durability due to a progression of the clot into a pannus. We have yet to conduct the serial echo studies over time or serial CT studies over time in order to better understand this part. We also in 2020 had the puzzling results from the Galileo clinical trial that despite how positive and encouraging the leaflet motion CT sub-study was in showing efficacy in reducing it with low-dose anticoagulation in the clinical side, that led to a higher rather than improved events, including mortality. And for TAVI, AF patients, we had a POP TAVI trial with a small caveat that the TAVI was performed on the uninterrupted anticoagulation. This may not be as generalizable. The combination therapy had a lot of handicap as far as bleeding and a modest handicap about the ischemic events. So we keep finding puzzling results left and right. And the more we look into these things, is it the population? It's a fact that nobody ever studied those, even from the part of the surgery for many, many decades. Or is it that we have a lot of work to do in order to create a randomized evidence basis that is going to properly inform the recommendations and unify the practice towards a patient benefit worldwide? I think the latter. Thank you for your attention.
Thank you very much, George, for this excellent summary. It obviously doesn't shed much light on things. They're getting very complicated. Are there any questions from the panel to George?
Okay. I have one question to George. I think the data regarding leaflet thrombosis and optimal antithrombotic therapy is so confusing. The thrombosis, looking at the natural cause, is very dynamic. The strong association between leaflet thrombosis and the cerebrovascular event is lacking. But the incidence of leaflet thrombosis is very high, more than 15%. But looking at the available data, Galileo trial was failed, and the popular TAVI Code A and Atlantis trial is upcoming in ESC and AHA meeting. So I think in the contemporary TAVR practice, on the basis of current available data, Dr. George Dangas, which antithrombotic strategy do you prefer or recommend for treating physician?
Well, the answer is that we haven't generated any data to credibly challenge the guidelines. We may have some hints, but the empirical guidelines of dual antiplatelet therapy stay 3 to 6 months. Dual antiplatelet therapy is reasonable. Do we have doubts that we may not need dual antiplatelet therapy? I think we do. But have we done anything to prove that? Not yet. So I think that summarizes it for patients with no need for oral anticoagulant.
George,
patients who do need an oral anticoagulant for another reason, we just give that for the most part, and you consider the secondary therapy if there is a specific reason, such as a coronary carotid stent or PAD or something like that.
George, don't all of the studies you've shown show that clopidogrel is not beneficial?
Yeah.
Why would you continue to use dual antiplatelet therapy today?
Well, that's a good question. And although there are several studies, the N is between 50 and 200 in any of these studies. Well, if you had a cumulative, I think there was a meta-analysis. I didn't show it because it had been shown several times in the past. And the meta-analysis of like 4 trials includes 400 patients or something. So really we're not talking into, and the POP TAVI, for example, that's again a 400 patient study. It was 150 patients per group.
But on the other hand, we have no evidence for dual antiplatelet therapy. So why would you give somebody the therapy without some evidence in favor of it?
Well, I think that's I think that's the next quest in order to study something in a more organized way, and maybe a simplified, pragmatic, simple trial may have a lot to do here, because the doubts are rising, and the end for any study is very low.
John, I mean, if you look at the beginning, we really didn't have much to prove when we started this antiplatelet therapy, except that we were looking, from the coronaries and try to kind of, mimic that for the valves, but we never had any clear evidence on it. And I'm inclined, looking at what we see and what you described, George, that clopidogrel really doesn't have any effect, whether we really need to do that. And simply the fact that we've done it is probably not enough. Yes, it's probably good reason to study it, but you think it's enough to justify just putting every patient on this type of therapy? I mean, you've answered that before, George. So
yeah, no, I'm glad we're in a difficult position here. We'd like to have, there's so many thousands and thousands of TAVIs thrown into all the registries in all the countries, and I think asking a simple question like that, I'm sure we can find ways to actually within a year answer it with all these thousands and thousands of patients being done. And there's been a little bit, I think, a little bit of a difficulty in the first years, even up a couple of years ago, because there was a lot of high-risk patients in frail patients. Maybe it was not easy to do this type of randomized trials. And even in Galileo, we tried to randomize patients we initially agreed to. Well, about 25% of them, they said that, we don't want to come back anymore because in general, it's onerous to come back. And I don't know, grandma and grandpa, they don't want to travel anymore. So, it's not the easiest to do. But now with a low risk group, maybe we have a more of a substance into trying to figure out this part of therapy.
So George, that was a fabulous summary. Eberhard, we're out of time. Do you want to say a few words in summary?
No, I leave it up to you because you did the introduction.
Well, I think if we have a couple more hours, we'll sort out this anticoagulation thing, but maybe not. Anyway, just a fabulous discussion, some great presentations, and I hope that was of interest to people in Korea. And thank you very much, and look forward to seeing all of you guys in reality at some point in the distant future. Bye now.
Distant future. Thank you very much, SJ.
Hopefully not so distant.
Thanks very much.
Thank you very much.
Thank you. All right.